Welcome to the Homegrown Heart Podcast every Friday at 7 a.m. Mountain Standard Time with your host, Dr. Amanda Ryan, DO, MBA, interventional cardiologist, and considered an expert in her field. This week's topic, medical staffing crisis in rural healthcare. Please help me welcome our host, Dr. Amanda Ryan.
Good morning, Carlsbad, Eddy County, listeners in Illinois, Florida, and everywhere. Today we're going to talk about artificial intelligence and how that can relate to the staffing crisis in, let's call that the world, in America, and in healthcare. We'll break it down from a macro to a micro level. Rural healthcare, and again, this is a recurrent theme, and in the next several episodes, I'm going to still be talking about some specifics of rural healthcare. I've shared with you guys some of my presentations about rural healthcare, a lot of the data, statistics, and, really trying to approach, what is the staffing crisis? What is the true... Are things exaggerated? Are they not? Statistics can be manipulated. Where are we really at? The nursing and physician plus any allied health field shortage in America is in a really bad way. I have commented before, but a recently reviewed nursing article stated that the average bedside nurse is working only 9 years total as a nurse from the day they graduate from a nursing program, and only 1 year average at bedside before moving into more paperwork or managerial, utilization review, case management, other kind of roles. And this is somewhat shocking to me. Trying to figure out if this is, what are the, we're going to root cause analysis this stuff. Why? You can't look at that data and not realize that what we're expecting of these nurses at the bedside must not be reasonable. You see some, and even though I'm not that old, had a recent birthday, but I'm a little old school in the sense of I did whatever I was told to do, took care of as many people as I had put on my plate in my training programs, did what and sometimes I'll see some of my old school nurse colleagues say, well, I had 7 patients on med-surg, et cetera. But those of them that have stayed aware of current stuff, like Cynthia Madrid, our director at our local cath lab, her and I were talking about the other day, and she said, yeah, I had 6 or 7 people on med-surg. But now there's often no CNA, 1 nurse, and the acuity of patients that get admitted have to be quite sick. 10, 15 years ago, we had things like your grandmother stayed with your parents and your parents were going out of town for the weekend and grandmother had a little bit of a cough. They took grandmother to the hospital and she got admitted for the weekend. We used to call it kind of respite care. She has a little bit of a cough, maybe she has a virus, but she really probably didn't need to be hospitalized. But we did those things. But if you're a nurse with 6, 7 patients, you're kind of happy to get a quote-unquote grandma in the mix because grandma's not that sick. It doesn't require as much charting or as much attention. There are no quote-unquote grandmas on admitting floors now at hospitals across America. If you get admitted to the hospital, you're sick. With that comes an increased acuity. When you're sick enough to be admitted to the hospital, you often need help with things like bathing, eating, dressing, using the restroom, all of these things. Now a nurse is going to take care of you, giving you your medications, explaining to you what's going on, handling your IVs, and she's also going to do all of those total care things for you. Plus liaison for a busy physician that's probably seeing 20 to 30 people in that hospital that day and is probably going to spend a total of about 10 to 15 minutes with the patient. So you've got nurses that are going to be responsible for, by the way, being in there when the physician sees the patient too. so that they can make sure they're aware of what's going on, that there's no confusion, and that they can help communicate that with families throughout the day, because the busy physician may not have time. So then that nurse is really helping fill those gaps as far as what's going on with the care. But doing that by providing total care, it's not about, even as a physician, will I help a patient onto a bedpan or use the restroom or clean up if they've soiled themselves? Yes, I will, and I can, and there's nothing, but again, then quote unquote, my work won't get done. I mean, we've shifted so much of the work away from the patient and to the charting, reporting, planning discharges, doing all of these things, that unfortunately our ability to really care for patients just continues to get stretched every day. So again, back to the nursing situation. So if we've got, no matter how many nurses we're graduating, then we have, and again, we go through these cycles with physicians and nurses where we say there's too many, there's not enough, which for years we've been saying in nursing there's not enough. But even with physicians, sometimes we go, oh, there's like too many ER doctors, we should back off that. All of a sudden, the utilization of our ERs in our population in certain areas has expanded to the point where we really need more ER physicians. But when you back off training programs, the ability, you don't just open them back up or give a couple more spots, or in training of nurses, of physicians, of rad techs, of all these different allied health fields, there's certain things they have to learn. There are state and national tests that have to be taken, right? So you can't, a program has to be able to provide that quality. Then you've got that. There are a lot of programs right now that unfortunately, if they weren't so protected by educational organizations like the ACGME, for example, they'd kind of use some of those trainees to fill roles that are not filled too, and not necessarily make sure they're getting the training that they need to be able to be competent at their positions when they're done. So I don't know if lay people have a real good understanding of that, but I trained at a program in Philadelphia for a year as a cardiology fellow, for example. And as a cardiology, quote unquote, fellow, that's what they call you when you are a specialist, you're a physician. You've already completed a residency. You could practice fully as a physician. For cardiology, it's internal medicine. So I had already had 4 years of training, 3 years of internal medicine, and a chief resident year by the time I started my cardiology fellowship. That means I could have worked in an ICU, I could have had my own practice, I could have done all of those things. And unfortunately, in this busy Philadelphia training program, the cardiology fellows were kind of being expected to try to learn what we could about cardiology while really filling staffing gaps on a daily basis as well. And, that's why the program eventually didn't continue, and I ended up transferring to a program in Florida. That's kind of can be devastating for your career, and for my colleagues and I, it was a very stressful, difficult time for us. And you're very torn as a physician in that position, like, I need to learn what I need to learn to be a competent cardiologist. But I see that Mr. X, needs my care in the ICU or on the floor, and I want to take care of him, but I also want to make sure I can take care of him when I'm a cardiologist in 3 years, or that I progress so I can become a cardiologist. All while doing that at a markedly reduced salary. So sometimes large hospital systems do see residents or nursing students or other students as somewhat quote unquote cheap labor, and that's really a dangerous situation. So the shortage exists, it's serious, and things got to be approached from a different angle. At our next board meeting for Partners in Heart Health, which is going to be this week actually, we're going to host the local college and some of our city administrators, and we're really going to work together focusing on some of the allied health fields and kind of discuss how the college is meeting the needs of the community with their allied health programs, and maybe share some ideas for how we could make their programs more robust, or how we could encourage some flexibility, or what does the college want to hear what they're doing about flexibility. Because again, this whole quote unquote flex learning, and again, I'm not in academics, I'm in healthcare, so I'm not, what I say about education may not be the exact correct term. So flex learning, but what does that mean? What exactly are our options for flex learning? And you got to think, a traditional nursing program is mostly an 8 to 5 Monday through Friday situation for 2 years. And it's usually 2 years full of completing prerequisites prior to that. And that would be just to get your first level, entry level RN degree for those 4 years typically. So when you think about that, is there any room to work at all for students during that? What about, the busy working mom that's really trying to go back and better her future? Maybe she's a CNA in a facility. Maybe she's able to even get her LPN, her licensed practical nurse, and now she's trying to get that RN. Those are the people I often mentor, and I love mentoring. But I am finding more and more that the cost of living in America and the lack of social programs and resources are making it that where that student, even with aggressive financial aid packages and reasonable tuition rates, and which we do have a lot here in New Mexico, they cannot afford to live, quote unquote. They can't pay their bills and do that. Well, then if I step in as an employer, even I have an employee that's in that situation, let's say, even if we can cover that employee or our foundation can help cover it, that's what we're really trying to get grants and donations for. That's what we do fundraisers for, to help patients in need and to help staff or others in the community that are really trying to better their careers in allied health. But there are no qualified people for me to put in their roles while they go to school full time. So it's very hard as a business owner to even figure out, how do I help? How do I become part of the solution? My mom used to say a lot, you can be part of the problem or you can be part of the solution. Don't come to me with just problems. You've got to come to me with potential solutions. The difficulty with that, though, again, is there's some times when I'm getting to a point where, I don't know potential solutions to this problem. And that's kind of a scary place to be when you get to that with a problem. I do think in healthcare, I have a lot of ideas. A lot of people have a lot of ideas. But we've got to turn ideas, again, into actionable processes. What are we going to do? And we really means everybody. You might think I'm an oil field worker, I'm a pumper out in the oil field. Or I'm an oil field executive. What am I worried about healthcare for and how? Because if you don't invest in your local healthcare, you won't have the option of getting good healthcare. People say, again, the survey for the city that we're doing for the comprehensive plan, I keep seeing the concerns about healthcare. What I'm not sure is that people realize you've got to be invested in what's happening in the healthcare in your region as well. There's no they are going to fix it, that we can just have a list of wrongs and complaints, sit back and think they are going to fix it. Who is they? Who does they need to be, quote unquote? If that makes sense, who needs to be on those teams? Who needs to be at this table? Who needs to be at the round table discussing it, or the square table? Who needs to be there? You need to be there too. You, the citizen. You, the employee at Albertsons. Meaning, you've got to tell what your healthcare needs are. You've got to listen to the issues. Sometimes if you're somebody with financial resources, you've got to be willing to put some of your financial resources towards progress in healthcare even. And you've got to understand it. I think if you go back to some of my podcasts, I think one of the really good ones had to do with who's at fault, quote unquote. And I talked about big pharma, insurance, physicians, and patients, big healthcare corporations. We're all five involved. The issues in healthcare are not just one, two, three, there's a lot of quote unquote blame to go around. So how are we going to work together to come up with real actionable solutions? Artificial intelligence, AI. I'm slow on technology sometimes. Again, we have the latest, greatest technology at Advanced Ambulatory Surgery Center of Carlsbad, New Mexico. And I am thrilled to be able to provide care to patients in the most state-of-the-art facility that I could have envisioned. But I'm not very good with fully understanding and embracing new technology in other realms besides the equipment I use in a cardiac catheterization lab or procedures. I can't change a light bulb, but I can thread a, stent and wire through your arm or your leg. It's just a unique skill that I have, I guess, right? Years of training. But I'm not very good at conceptualizing. I can turn the computer off and on, and I can maneuver the programs that I know. But again, the charting part of healthcare, I see a large volume of patients because that's what the need is in this community and surrounding areas. I cannot spend 24 hours every weekend working on those notes, really, because I have a lot of other things I need to be doing too. Not personal as much as they are business owner and reading studies that the patient had and other things that only I can do. So really trying to incorporate artificial intelligence and a scribe into really getting our notes thorough so that we can share them with the patient's other providers and the insurance plans to make sure that everything is documented appropriately. So there's a learning curve there, but the more we're investing in some time in it, we're realizing that it's making things easier. I currently do my procedures on patients, walk out of the room, and that report is done within 5 minutes. Usually within 30 seconds to a minute, I've done the report for the patient. That's a huge flow shift for me because in the past, I typed a few notes about what it found and the goal is to have those reports done within 24 hours, but there would be times I was 2 and 3 weeks behind on getting those procedure notes. The insurance wants them, the other physicians want them, the patients want them, and I would be struggling to really try to keep up with the current day as well as try to get that stuff done. So using artificial intelligence has been helpful, but we have about 6 layers of security in our systems as well that we're using though, trying to make sure that we protect patient information because cyber attacks in healthcare have become a major issue lately. And so the more outside software you bring in is the more potential for exposing sensitive data. And sometimes that data, not only can it be used for financial gain, it can be used for insurance denying patients certain life insurance, increasing their premiums. So there's some information they should have access to, some they shouldn't. And patients need to know what insurance has access to and what they don't. They can say sometimes as far as, your life insurance, if you apply for something and they start asking you certain questions, maybe you decide that you don't really want to go forward with applying for that policy. You don't want them on the quote unquote dark web to be able to get some of your information. And so us trying to protect your information is a whole 2 employees and thousands of dollars a month in just protecting information. Next up is trying to incorporate, we have 35 to 40 staff members at any given time. Again, this is not a mom and pop cardiology or any physician practice with 2 or 3 staff and we're in there making it happen. That's really not true. Again, we've got 35 to 40 staff, about 25 to 30 on site and about 5 to 10 at any given time working remotely to help really meet the needs of our patients in this area. There are people working on getting your test approved. There are people working on making sure your referrals to outside doctors, that they get the information, that we get that information flow back, that not only do we get the information, but that we get it sent out and back in a safe manner. phone calls. Again, there's time, we might get 500 to 1,000 phone calls a day. How do we really, we have 4 and 5 people in our front. How many, and some people are like, we just got to hire more. Do you need help? I've had people before frustrated with our phone system, ask me things like, well, do you need more help? I can come up there and help you answer the phone. Well, first of all, somebody that can just answer the phone at our practice but isn't really know too much about our practice or cardiology is not really that helpful. I know my former practice in Florida is actually offshored to India, their phone answering. But I feel as though the frustrated patients enough that can't get through to our office, I'm trying to imagine them getting through to a foreign call center trying to handle their call. I don't feel like that's going to be a very good option. So we're really looking into artificial intelligence and what are a lot of those phone calls coming in. Many of them are just, what time is my appointment, or can I change or cancel my appointment? Or other doctor's offices saying, I referred so-and-so to you, did they get an appointment? So we're really thinking if we can have an AI and train that AI to just give the patient date of birth, look up, change, figure out where an open appointment is, slide that patient into that, tell them if the patients have certain appointments, that may shift a good, potentially a third of our calls. Maybe that allows then for staff to do a better job of focusing on the tasks in front of them, the patient in front of them, as well as the other phone calls. The the patient portal. We have a portal. We encourage the portal at AHV&M that you send messages through there. We respond to your portal questions. We have people at home working, responding to your portal messages, trying to interact with us, the providers, and figure out what you need to do. So I guess what I was kind of hoping to do this morning was to talk a little bit about where this crisis really is. Again, the number of open positions in rural areas is just, it's staggering in healthcare. I think my two-prong approach right now with the biggest ways are seeing AI, and I don't see it replacing humans in jobs, by the way. I see it making us more efficient. But how can we do that in a quote-unquote safe manner? And then the second thing is, how can we adjust education programs, get the students interested in the allied health fields? What are we really doing to partner? I think the healthcare systems in a community have got to partner with so many parts of the community. And that starts with partnering with our elementary schools even, with our middle schools, our high schools, our colleges. Where are these partnerships? And is there room that we can advance them? We can get young women interested in STEM programs. And I know we have iScience and some really great programs here in our community for that. So kind of just trying to figure out, is there any way we can improve some of the programs and interaction that we do have going on? So I hope by listening this morning that you're motivated to be part of the solution. And I hope you have a great week. We'll see you next week.